We'll see the continuation of last lecture, that is development of urinary system. So our objectives of this topic is the basically the three evolutionary stages of kidney: pronephros, mesonephros, and metanephros, which I have seen last time, right? Then today we'll see the development of the definitive kidney, that is collecting part of the definitive kidney and secretory part of definitive kidney, followed by the ascent of kidney, change in blood supply during ascent, rotation of kidney, molecular regulation, and congenital anomalies. Okay. So let's revise the last lecture. So can you tell me kidney developed from? Yes, what are the two sources? Come on.
Cloaca.
So kidney developed from? Yes, which part? The intermediate mesoderm. Right? I could not hear. Somebody is speaking. Abhijit Singh. Okay. So let's revise in short. The kidney derived from the intermediate mesoderm, which is present in the intraembryonic mesoderm, right? So this intermediate mesoderm, after folding, give rise to two parts, right? The lateral part forms a nephrogenic cord, which forms the kidney and urinary system, while the medial part will form the genital ridge, which give rise to gonads, right? This nephrogenic cord, this is extend craniocaudally from cervical to sacral region. Am I right? And it gave rise to three evolutionary stages of kidney: pronephros, mesonephros, and metanephros, which is developing craniocaudal sequence. Okay, so these are the three stages which are developed in the nephrogenic cord of the intermediate mesoderm. Now, the pronephros, which is present in the cervical part, it develops, yes, which the duration, which time it develops? By early fourth week of intrauterine life. How it is presented? It is presented as a nephrotomes, segmented, and these nephrotomes are consist of external glomerulus and internal glomerulus. The external glomerulus, which opens into intraembryonic coelom, while internal glomerulus, they are opening in nephric duct. So these pronephric tubules, they open into nephric duct. These pronephros are, yes, non-functional. It is functional in which primitive animals? Which primitive animals? Can you hear me? Can you hear me? Hello. Yes. Yeah, okay. So
Yes, ma'am.
this pronephros is basically functioning in cyclostome and teleost fascias. Immediately it degenerates. While it degenerates, the metanephros appear. The mesonephric part, blue color part. Sorry, this is a mesonephros. As this pronephros degenerated, mesonephros appears, and they are in the form of two parts. What are these? Glomerulus and the mesonephric tubules. They open into this mesonephric duct. So this is a mesonephric duct where it opens, and this is nothing but the nephric duct. After opening, this is called as mesonephric duct, which ultimately open downwards in the cloaca. The number, it is almost 10 to 50 in each kidney, and they developed by the late fourth week. They are functioning for 4 to 5 weeks, right? And they are functioning in which primitive animals? They are amphibians and some fishes. So this is mesonephros. Just a summary of last lecture. And you can see the structure, which is well formed, the glomerulus and the tubule, which ultimately open into this mesonephric duct. While it start degenerating, not all the mesonephric tubules degenerates. The only caudal part remains like this, and they form the they contributes the gonads. Okay, they contributes the duct system of the testes. So this is mesonephros. As mesonephros start disappearing, the metanephros start appearing in the sacral region, and this is basically the metanephros, which is formed, which is unsegmented. It is forming ultimately definitive kidney. It is present in higher vertebrates, right? And it ultimately forms a definitive kidney. This, till this part, in the last lecture, we have seen in detail three evolutionary stages of kidney, right? Now, these three stages, which are the evolutionary stage, they are seen in sequence in the development of human kidneys. So this is the ideal and classical example of saying that ontogeny repeats the phylogeny, right? So ontogeny repeats the phylogeny is this saying is ideal for development of human kidney because all three stages you see during its development. So this is the in short the table. You can make a screenshot. Okay, can you do the screenshot? Screenshot ले सकते हैं आप. So you can
Yes,
take the
ma'am.
screenshot, yes, and then you
Yes,
can
ma'am.
revise it. This is basically the tabulated form of three stages which are showing all the structures. Okay, so this is region, location, segmentation, time of appearance, functional status, and what are the ducts. So this is how you can quickly revise these stages. Now today we'll see after formation of this metanephros how this definitive kidney is formed. Okay, so this definitive kidney is basically having two parts: the collecting part and secretory part. What is the collecting part? Collecting part consists of the collecting tubule, collecting duct, minor chelicus, major chelicus, renal pelvis, and urine. And how it develops? It is developed from ureteric bud. It develops from ureteric bud. While secretory part, which is developed from metanephric blastema, which is developing metanephros, and it consists of glomeruli, Bowman's capsule, PCT, DCT, and loop of. If you could not able to write completely, you can make screenshot so we can revise it again. Collecting part, it is developing from ureteric bud. Ureteric bud, this bud is basically arises from, this is outgrowth bud, this arises from distal part of mesonephric duct. It is also called as Wolffian duct. Okay, so mesonephric distal part, the small bud is arises, which is called as ureteric bud, and it appears by 5th week of gestation. It grows cranially and it ultimately grows towards the metanephric blastema, penetrates it. And once it penetrates, I will show you the figure, it gets dilated. It's blind end, it is blind end and it is dilated from the ampulla. This ampulla represents the future renal pelvis. So it forms the primitive renal pelvis. So you know collecting part consists of ureter, urinary pelvis, chelicus, and collecting duct and collecting tubule. So the renal pelvis is derived from the dilated ampulla, which is the end of ureteric bud. So here you can see this is mesonephric duct. From the distal end, just before it opens in cloaca, this ureteric bud arises. It grows towards the metanephric blastema. It penetrates it, make its dilatation, and this is called as ampulla. And this ampulla give rise to the primitive renal pelvis. Then there will be two divisions. What two divisions? One cranial and one caudal. You can see here the one cranial and one caudal. And these division which ultimately forms the major chelicus. Further, each division will divide into two And the second, third, and fourth generation of division, they absorb and form the minor chelaces. And fifth division onward, this is the fifth division onward till periphery, it is almost 12 or more the generation of divisions. They form the remaining part of collecting system. What is that? The collecting duct and collecting tubules, right? So this is how the collecting part is formed. So let's see how this part is formed. First is ampulla, which is the blind dilated end of ureteric bud forms the pelvis. Then they split into the cranial and caudal portion. They form the future major chelacis. Total number of branching generation is 12 or more generation of branching. Okay, and it continue till the fifth month of intrauterine life. See, this is slightly different. I am taking this from Langman. Your book mentions slightly differently. So follow this. So second order enlarge and absorb the third and fourth generation. So second, third, and fourth generation, they absorb and contributes minor chelasis. Fifth till 12th or more generation, they elongates towards the periphery and they contributes the collecting duct and collecting tubules. And these tubules, they are expanded and then they converge towards the minor chelacis and they form renal pyramid. Okay, so renal pyramid is formed by this collecting duct and collecting tubules, which is formed by the fifth and successive generation, which converts towards the minor chelacis. So this is the collecting part. The summary is it is derived from ureteric bud. The ampulla gave rise to renal pelvis. First generation branching is major chelacis. Second, third, and fourth forms the minor chelacis. Fifth onward is the collecting duct and collecting tubules. Okay. So this again picture, it is explaining very nicely. This is a mesonephric duct, ureteric bud, expanded part, and these are different generation of branching give rise to from renal pelvis till collecting tubule. Still the ureter is remaining, which is also a part of collecting part of the kidney. So how it is developed? So this ureter is developed from this caudal part of the this renal pelvis till it's opening into mesonephric duct. Okay, so this is the ureter, which is derived from the caudal part of renal pelvis till it's opening into mesonephric duct. So this is the ureter, which is the last part of this collecting part of the kidney. So part of ureteric bud, caudal to primitive renal pelvis, till its opening in mesonephric duct, form the ureter. So ultimately, this ureteric bud gave rise to, what are the parts derived from ureteric bud? The first is ureter, renal pelvis, major chelacis, minor chelacis, collecting ducts, and collecting tubules, which are 1 to 3 million in number. Okay. Now the second part. The second part is secretory part, which is nephron. How it is derived? It is derived from metanephric blastema, which is developing metanephros in the sacral region. This metanephric blastema, when they come in contact with the ampulla or the end of ureteric bud, undergo differentiation and form the nephron. This differentiation is induced by ampulla. So there is an induction by the ureteric bud, which give rise to differentiation of metanephric blastema into nephron. Okay, and this molecular regulation we'll see in the last. So what are the steps of this secretory part? So this secretory part, how it is developed? The cells of metanephric blastema form the solid clumps. They form the cluster, and they are clumps around the ampulla, and this is called metanephric cap or the cap stage. What is a cap stage? The cluster of cells, this surrounds the ampulla and form the solid clump, and this is called as metanephric cap. Now, gradually this cap is converted into the vesicle, which is a modified cap gets modified and form the vesicle. This vesicle forms later on the pear shape, and then comma shape. This comma shape further expand to form the S shape. Okay, so you can see here again, this is a picture from Langman. It is showing this collection of the cells from the cluster of cell collected surrounding the end of the ampulla, and they ultimately, this is a cap stage, they ultimately form the vesicle. This after vesicle, here it is clearly seen, this is a pear shape, comma shape, and then S shape. And this S shape ultimately later on forms the well-developed nephron. What happens to this S-shaped tubule? It's proximal end and distal end. Proximal end, which is still it is not connected. Here it is not connected with the collecting part. Now it gets communicated. So this proximal end of this tubule gets communicated with the collecting part. So now the urine flows freely from this into collecting part, while distal end expand and form the cup-shaped Bowman's capsule with the insertion of capillaries to form the glomerulus. So this after S-shaped formation, okay, so this is the S-shaped tubule which is formed. After this distal end comes to invaginate by tuft of capillaries, so they form glomerulus and Bowman's capsule. Okay. And the proximal end is narrow, gets communicate with the collecting tubule, so that now whatever filtration occurs in urine is formed, it gets freely entered into collecting part. Lastly, this S-shaped tubule which give rise to different parts of the nephron, that is the glomerulus, Bowman's capsule, PCT, loop of Henle, and DCT. So till these parts, they are derived from S-shaped tubule, which are formed by metanephric blastule. Metanephric blastule. So this is secretory part. So again, it is giving the same stages, the cap stage, vesicle stage, pear shaped, here only the comma shaped appear, and then S shape. And which till this stage, there is no communication. And then this proximal part get communicated and distal part forms the glomerulus. So this is how whole secretory part is formed. So again, you can take a screenshot. This is showing in short, the flow chart of this collecting and excretory part. Okay, so collecting part from the ureteric bud give rise to all these parts, while excretory part from metanephric blastema give rise to the Bowman's capsule, glomeruli, and all the parts of nephron, that is PCT, loop of Henle, and DCT, right? And later on, both get communicated. So very nice flow chart. So to revise it. Now, once this definitive kidney is formed, still it is in sacral region, right? So it is developed, metanephric blastema is developed in the sacral region. So it is still in sacral. It has to ascend to its normal definitive position. So how this ascent occurred? Why this ascent occurred? So by 9th week of intrauterine life, this kidney ascent from the sacral position to thoracolumbar position. So what is the definitive position? Can you tell me what is the extent of adult kidney? From which vertebra to which vertebra? Yes.
L1, L2, L3, L4.
L4 तो नहीं है. T12 to L3. हाँ, yes. T12 to L3 is the definitive position. It has to ascend till this position. But you know the right kidney is slightly lower than the left kidney. And why? Because of the developing right lobe of liver. So it arrests this for the ascent. So the right is slightly lower as compared to left. Why there is a need of ascent? Why there is a need of ascent? So first and most important reason is for better blood supply. Why better blood supply? When it is in the sacral region, it is having nourishment by the median sacral artery. And as this kidney start developing, that nourishment is insufficient. It is a very small artery. So in search of better blood supply is gradually go on ascending. Second reason is smaller pelvic kidney. So other pelvic organs start developing. So because of the inadequate space, it search for larger space and it start ascending. Third reason, differential growth of posterior abdominal wall. And the last one is reduction of fetal curvature. So these are the four important reasons. Because of this, kidney start ascents. Okay. So now this figure, this is Langman's figure again. It is showing the developing kidney in the sacral region and then is gradually ascent in the thoracolumbar region. This is the figure showing in search of better blood supply. So blood supply is gradually changing from here to here, and ultimately which the artery which is forming, this is a lateral splanchnic branch that we'll see in the next slide, which ultimately form the definitive renal artery. Okay, so this is the ascent and its reason. Again the same, here you can see the right kidney is slightly lower as compared to left kidney. So it ascend till the, what I could not understand, Tanuja. Okay. Oh no. What happened? Sorry. It's not going.
Clear.
Okay. What happened, Tanuja?
Ma'am, I was taking the screenshot and something happened wrong.
Okay, I am also not able to. It's not going forward. आगे नहीं चल रहा है. Okay, I will call someone. Excuse me. अरे ते काहीतरी झालं. पुढे जात नाही साईड काहीतरी झालं. साईड पुढे नाही जात. काहीतरी इथे माझी बटन दाबली.
अप्रूव्हल याच्यात आलं.
हा काहीतरी अप्रूव्हल आलं. नाही करायचं का?
Yes, madam.
Okay, sorry for disturbance. So this is we continue till the part of the ascent. Okay, so we finished the ascent. Now we'll go for the blood supply. So as I said, in search of blood supply, the kidney ascends. So what is the different blood supply of this kidney while it's ascending? The first artery which is supplying this kidney in the sacral region is median sacral artery. As it ascends, so the different branches of aorta take over the blood supply. And these are the lateral splanchnic branches of aorta. And finally, when it reaches the definitive position, the lateral splanchnic branch of the aorta at the level of L2 vertebra, it forms the definitive renal artery. Okay, so this is sorry. So these are the different arteries which supplies the kidney. The definitive renal artery is formed by the lateral splanchnic branch of the aorta at the level of L2, which ultimately form the renal artery. So it is very nicely shown in this figure. This is median sacral artery, lateral splanchnic branches, and the lateral splanchnic branch at the level of L2, it forms a definitive renal artery. Now, it is definitive kidney is formed in the sacral region. Now it gets ascent it gets a better blood supply supplied by now definitive renal artery. What happens next? The last step is the rotation. Okay. So these arteries which are formed during ascent, sometimes they may persist. Many times you might have seen during dissection, the additional arteries are also present which are entering in the hilum or through upper or lower pole, and they are called as the supernumerary arteries or the accessory renal arteries. Okay, they may persist. And during ascent, there is one more thing, that is the right and left umbilical arteries. Right and left umbilical arteries, they form the fork-like structure, and between these two, the kidney ascent. If this ascent, during ascent, these arteries come in the way, they could not able to ascend and they remain in sacral region. So if there is any hurdle during the ascent, like the umbilical artery, they come in between, so they remains in the sacral region in adult life. Okay? So this is one of the congenital anomaly. So now it reaches its normal position, that is T12 to L3 vertebra. Now what happens? Here the hilum is still facing anteriorly facing hilum, so it has to rotate. So there is the last stage is the rotation of kidney. It rotates by 90 degree towards the medial side. So the first hilum is facing anteriorly, and now it rotates towards the medial side. So now the hilum is facing medially, and the convex border goes lateral. So this becomes the definitive position of kidney. Okay. So first, all three evolutionary stages are formed. Second will be there is the metanephric kidney, which forms the definitive kidney by development of collecting part and the secretory part. And then there will be ascent, change in blood supply, and rotation. Okay. So this is, you can see the rotation. As it ascends, the hilum remains faces ventrally, and after rotation, this 90-degree rotation, the hilum faces medially and the convex border goes flat. There is one thing still has to happen. This fetal kidney is lobulated kidney. But you know the adult kidney is having smooth surface. They are not having lobule. So these lobules get disappears after birth. So, and they achieve the shape of definitive adult kidney. So until birth, the nephron number is almost 1 million in number, and this number remains fixed. After birth, the number does not increase, but kidney is having lobulated appearance. This lobulated appearance will disappear by the age of 1 year, that is around infancy. How it disappears? By the further growth of these nephrons. So these nephron grows, and that will causing this lobulation to be disappeared, but number does not increase after birth. Whatever number is there till birth, that remains fixed. It will not increase. Only lobulation disappears and the surface becomes smooth. So this is the last part of the development of kidney. Now the molecular regulation. So it is too many molecules which are basically regulation. They take part in regulation. You should know at least these 7 molecules you're supposed to know. So you should know how this molecular regulation occurs. So it is a reciprocal induction between metanephric blastema and ureteric bud. The molecules from ureteric bud give signaling towards the metanephric blastema, and molecules from blastema, they induce signal to the ureteric bud. So there is a reciprocal induction. Both will induce each other. So how it happens? The transcription factor WT1. This is expressed in the metanephric mesenchyme, which regulate the two factors, the HGF and GDNF. Okay? HGF is hepatocyte growth factor and GDNF is glial-derived neurotropic factor. And from ureteric bud, the two expression, BMP, that is a bone morphogenic protein, and the FGF, fibroblast growth factor. Okay, and the PAX2 and WNT4. So we'll see in detail how this molecular regulation occurs. So WT1, which is expressed, that is, what is WT1? It is a Wilms tumor suppressor. It expressed in metanephric blastema, and it regulates the production of GDNF and HGF. Where it is produced? It is produced in metanephric mesenchyme. Regulator. So WT1 is the most important factor which ultimately regulates GDNF and HGF production. How they act? They stimulate the epithelial receptors which are specialized on ureteric bud. So these GDNF and HGNF, they act on the ureteric bud. They give signaling to the ureteric bud for its induction. Okay, and that is via the two receptors. These are tyrosine kinase receptor, RET for GDNF and MET for HGF. Same way, there is a reciprocal induction by ureteric bud which induces the mesenchyme of metanephric blastema via FGF2 and BMP7. So GDNF HGF helps in induction of ureteric bud, while ureteric bud helps in induction of the metanephric mesenchyme. So when you summarize, the GDNF HGF is helping in induction, basically the induction of ureteric bud, which is also called, and the start of branching of ureteric bud called as branching morphogenesis, right? And subsequent branching is controlled by EMX2, PAX2, WNT, FGF, and BMP family. So again, you can take the screenshot so you can revise it again. The same way, the BMP7 and WNT 4. These signaling, they are which are produced in ureteric bud, responsible for formation of nephron, that is differentiation of nephron. Two more factors, laminin and type 4 collagen. They form the basement membrane. You know type 4 collagen is present in basement membrane. So they help in formation of basement membrane for epithelial cells. So this is the figure from Langman explaining everything. So WT1, which is expressed in, this is a metanephric blastema. They helps in production of GDNF, HGF for acting on or induction of ureteric bud. The receptors which are present here are RET and MET, right? The same way BMP and the FGF, which are produced by ureteric bud, they induce the metanephric blastema. Further branching is basically controlled by WNT4 and PAX2. Okay, so this figure is also explaining very nicely about the molecular regulation. So this is the last part, that is the congenital anomalies of kidney. So these are renal agenesis, renal hypoplasia, hyperplasia or hyperplasia, duplication, that is additional kidneys present on one side, hydronephrosis, the anomalies according to shape, anomalies according to position, anomalies of rotation, the congenital polycystic kidney, aberrant renal artery, Wilms tumor, and congenital anomalies of ureter. So should I continue or I will take it in the next lecture? Yes? Anybody? Continue. Okay. So it will take 10 around. Acha. So I think it will take 10 minutes, but if you want to continue, I will continue, or it will be next, because Manju madam.
Continue, ma'am.
Continue, ma'am.
Continue. Okay.
Continue, ma'am.
So okay, I will continue. Or if something is remaining next time, if you request, I can revise it. Okay. So this most of the things you know. Agenesis as absence or could not able to develop. It can be unilateral or bilateral. Okay, so here there is a kidney is absent on one side. So agenesis. Agenesis is absent of kidney. It can be unilateral or bilateral. Cause is mutation in genes that regulate GDNF expression. Okay, so mutation is the cause where the agenesis occurs. Hypoplasia is underdeveloped kidney. You can see this is the normal kidney and this is underdeveloped. So it can be again unilateral, bilateral. Bilateral give very bad prognosis. Unilateral may remain, the person may remain normal in whole of his life. This is duplication, where on one side there is an additional kidney is there. Extra kidneys appear. It can be separate or it can be fused with the normal. Okay, so this is duplication. Many times a short note comes on congenital anomalies of the kidney only. Okay, so you should able to enumerate all with the important features. According to shape, it is different shapes of kidney. You can see here is the horseshoe kidney. Horseshoe kidney. What happens here? The lower pole of these two kidneys get fused, and this connecting isthmus, which is formed, it is developed either in front of aorta or it may be behind the aorta. Most of the time it is in front of aorta, and this level is remaining at the lower lumbar. These type of kidneys are at the lower lumbar region. Why? Because here you can see the inferior mesenteric artery, which is a ventral branch of abdominal aorta, right? So it is giving the prevent its further ascent. Okay, the root of inferior mesenteric artery, which is approximately at L3 level. So it could not be ascent because of the isthmus. It remains in the lower lumbar part. Okay, so this inferior mesenteric artery prevents its further ascent. Its incidence is around 1 in 600. So this is according to shape. There are different shapes. First is horseshoe kidney. Second is pancake kidney. What happens here? Both the poles get fused and gives the complete disc shape or the pancake shaped kidney, which can be most of the time midline or it may be on one side. So this is pancake. This is second shape. Then lobulated kidney. The lobulated kidney is basically the fetal lobulation which are present at birth. It remains as such. They remains or persist in adult life also. So this is lobulated kidney. This is again according to shape. So according to shape, we have seen three types of kidney: the horseshoe, pancake, and lobulated. Now according to position. According to position, kidney could not able to ascend. The failure of ascent. It may be remain in between its ascent. So it could not ascend, it will remain in pelvic region. It is called as pelvic kidney. It may be in the lumbar region. It is called as lower lumbar kidney. Or sometimes it will ascend beyond its normal position, that is in thoracic region, and that is called as thoracic kidney. So three abnormal positions: pelvic, lumbar, and thoracic kidney. So this is according to position. You can see here very nicely one kidney is in normal position and second is in the pelvic region. Next is crossed ectopic kidney. The kidney develops on both the side, but it crosses towards the one side. Both the kidney it appears on the only one side of the midline. Here you can see the ureter of the displaced kidney crosses to opposite side across the midline. So this ureter can cross and may produce pressure effects. Okay. So ectopic because position is abnormal and it is crossed from one side to the other side. Now abnormal rotation. You know it is rotated 90-degree medially. So if it is not rotated, it is called as non-rotation. If it is incompletely rotated, it is called as incomplete rotation, or it can be reverse rotation. Non-rotation, here the hilum is, you can see here, directed anteriorly. Incomplete rotation, where the hilum is directed anteromedially. It is not properly anterior or it is not properly medial. It is remain in between the anteromedial. It is reverse rotation. Here this figure shows the reverse rotation. Here it goes towards the anterolateral side. So it can be non-rotation, incomplete rotation, or reverse rotation. Okay. So this is abnormal rotation. The next position, next anomaly is aberrant renal artery. So that we have seen during ascent also. The embryonic vessels during ascent which are formed, they remain persist. They persist and they form the aberrant renal arteries. They arises from aorta and they may enter through the superior or inferior poles of the kidney. They may form the only supply. Many times renal artery is missing and this accessory renal artery is the only blood supply to the kidney. And they may obstruct the ureter also and forms a hydronephrosis. This is very important condition, very common condition, congenital polycystic kidney. It is also called as PKD, that is polycystic kidney disease. Okay, here you can see the kidney is studded with the multiple cysts. These cysts are filled with the urine. The reason this figure is showing the cause. Here you can see normal condition where both the collecting and secretory part gets communicated. But here you can see there is a failure of communication between the two parts. So that the whatever urine is formed, it gets collected here only, could not be able to pass through collecting part. So cysts are formed. Okay. So it is a commonest congenital anomaly of kidney. It is usually bilateral. Remember, it is bilateral. The cause is failure to establish contact between the excretory and collecting part. And this leads to formation of cyst. Few books mention the recent view. They are not saying this failure to establish contact between the two. They are saying it is derived from abnormally developed collecting tubules. So you can explain both the causes why this PKD develops. These cysts are filled with the urine. The numbers, they are hundreds to thousands of such cysts which are present in the kidney. Diameter, it is variable from few millimeters, it may increase up to 10 centimeters. And because of this multiple cysts, normal renal tissue get compresses and they get destroyed. This kind of PKD are of two types, either autosomal recessive or autosomal dominant. So it is also called as ARPKD or ADPKD. So what is ARPKD? Is autosomal recessive polycystic kidney disease seen in childhood. It is the symptom appear very early, just after birth, and having very bad prognosis. Very early, the child land in the renal failure. Incidence is 1 in 5,000 birth, and the cause is mutation of PKSD1 gene. So this is one type which is having a bad prognosis, very rapidly progressive, seen in children's. The second condition is autosomal dominant, ADPKD, autosomal dominant polycystic kidney disease. Here, this is the incidence is more common. It is so incidence is around 1 in 500 to 1,000 births. It develops in adulthood, that is 30 to 40 years, and it is less progressive. Okay, it does not progress as faster as compared to ARPKD. Cause is mutation in short arm of the chromosome 4 or chromosome 16. So ultimate treatment, because they both the cases they land up in the renal failure, so treatment is either dialysis or kidney transplantation. So this is the PKD, polycystic kidney disease. In clinical practice, we will be more aware of these conditions, PKD. Simply just like this, there is one more condition where multiple cysts are there. It is called as multicystic dysplastic kidney disease. It is slightly different from PKD. How it differs? The reason is dysmorphology. Dysmorphology is the development itself is abnormal. In polycystic kidney, there is a halt. There is no, they could not able, the secretory and the collecting part could not able to communicate. Here, the dysmorphology is there. Abnormal development. It is common in children, but they are unilateral. PKD is always bilateral. Outcome is good. Then cyst number is fewer, where in the PKD there are thousands of cysts. Size is also very small, few millimeter to centimeter. And which part is dilated? It is usually the dilatation of a loop of Hindley of the nephron, some part of the nephron, especially the loop of Hindley. So this is slightly different. So you should able to differentiate between the PKD and multicystic kidney disease. Okay, and this is the last one, which is the congenital Wilms tumor, which is a cancer of the kidney seen in children. Okay? So Wilms tumor, which is the malignancy, it is seen in children aged by the 5 years of age. Incidence is 1 in 10,000. And what is the reason? Reason is due to mutation in WT1 gene on 11p13 chromosome. Okay? So this is Wilms tumor. And this we'll see in the next time, the congenital anomalies of ureter. Because ma'am is also there, is already there. She will start the next lecture. So we'll continue with the congenital anomalies of ureter, with the development of urinary bladder and its anomalies. And if possible, we'll start with the development of urethra also. So that will complete the urinary system. So any queries? Okay. So thank you.
No, ma'am. Thank you, ma'am.
Thank you.